As a family nurse practitioner, your role in managing women's health is fundamental and far-reaching. You are often the first point of contact for women seeking care across their entire lifespan. This unique position requires a deep and practical understanding of reproductive and gynecological health issues. From the first menstrual cycle to the postmenopausal years, your knowledge directly impacts patient well-being, disease prevention, and early intervention. Mastering this area is not just about passing your certification exam. It is about providing compassionate, evidence-based care that empowers women to lead healthier lives. Your ability to navigate these sensitive topics with confidence and expertise builds the trust that is essential to the provider-patient relationship. The scope of women's health within primary care is incredibly broad. It encompasses routine wellness visits, cancer screenings, contraceptive counseling, and the management of complex conditions like polycystic ovary syndrome and endometriosis. You will be tasked with educating patients, interpreting diagnostic tests, and developing treatment plans tailored to individual needs and life stages. This requires a solid foundation in pathophysiology, pharmacology, and the latest clinical guidelines. Being well prepared means you can address common concerns effectively, recognize subtle warning signs of serious illness, and ensure your patients receive the highest standard of care available in a timely and efficient manner. Your preparation for the FNP exam must include a thorough review of these core competencies. The exam will test your ability to apply knowledge in realistic clinical scenarios. It will ask you to differentiate between benign and malignant conditions, select appropriate contraceptive methods, and manage the symptoms of menopause safely. Understanding the nuances of these topics is critical. For instance, knowing the specific risk factors for ovarian cancer can lead to earlier suspicion and diagnosis in a high-risk patient. Similarly, being up to date on the latest cervical cancer screening guidelines from organizations like the American Cancer Society ensures you are practicing according to the current best evidence. Ultimately, your proficiency in women's health is a measure of your readiness for independent practice. It reflects your commitment to patient safety and your role as a key healthcare provider in the community. As you study, focus on the clinical pearls and danger zones associated with each condition. Think critically about when to treat in the primary care setting and when a referral to a specialist, such as a gynecologist or oncologist, is warranted. This thoughtful approach will not only help you succeed on your exam, but will also make you a more effective and trusted clinician for the many women who will depend on your care throughout your career. Breast cancer screening guidelines are designed to detect cancer at its earliest, most treatable stage. For average-risk women, mammography is the cornerstone of this effort. The American Cancer Society recommends that women have the option to begin annual screening with mammograms at age 40. It strongly recommends that all women should begin annual mammography by age 45. Women can then transition to biennial screening, which means every 2 years, starting at age 55. Or they may choose to continue with annual screening. It is crucial to engage in shared decision-making, discussing the benefits and harms of screening with each patient. Clinical breast exams are no longer universally recommended for screening average-risk women, but remain an important diagnostic tool if a patient presents with a complaint. Cervical cancer screening has evolved significantly with the understanding of the human papillomavirus as its primary cause. Current guidelines emphasize HPV testing. For individuals aged 25 to 65, the preferred screening method is a primary HPV test every 5 years. If primary HPV testing is not available, co-testing, which is an HPV test combined with a PAP test, every 5 years is an acceptable alternative. Another option is a PAP test alone every 3 years. Screening is not recommended for individuals under age 25, as HPV infections are common in this age group and usually resolve on their own without causing cellular changes. Likewise, screening can typically be discontinued after age 65 for those with a history of adequate negative prior screenings. Knowing when to refer a patient is a critical FNP skill. For breast health, any suspicious finding on a mammogram, such as a BI-RAD score of 4 or 5, requires immediate referral for further imaging, like an ultrasound or MRI, and likely a biopsy. A palpable lump that is hard, painless, and fixed to the skin or underlying tissue is a major red flag that warrants prompt referral to a breast specialist or surgeon. For cervical health, abnormal screening results guide the next steps. A positive HPV test, especially for high-risk strains like HPV 16 or 18, or abnormal cytology findings such as ASCUS, LSIL, or HSIL on a PAP test, requires a referral for a colposcopy to visualize the cervix and obtain biopsies if necessary. A key danger zone in screening is failing to follow up on abnormal results. It is the provider's responsibility to ensure that the patient completes the recommended follow-up tests and consultations. Another danger zone is misapplication of guidelines, such as continuing to screen an elderly patient who has had consistently negative results and a limited life expectancy, or not appropriately screening a high-risk individual. Patients with a strong family history of breast or ovarian cancer, a known genetic mutation like BRCA1 or BRCA2, or a history of chest radiation therapy require a more intensive, individualized screening plan that often starts earlier and may include MRI in addition to mammography. Fibrocystic breast changes are a common benign condition that affects many women, particularly between the ages of 20 and 50. The key characteristic of fibrocystic changes is the presence of lumpy, tender breast tissue, often described as rope-like or nodular. These symptoms typically fluctuate with the menstrual cycle, becoming more pronounced in the luteal phase, just before menstruation begins. The pain and lumpiness usually improve after the period starts. The lumps associated with fibrocystic changes are often multiple, found in both breasts, and are mobile, meaning they can be moved easily under the skin. Nipple discharge, if present, is often bilateral, multiductal, and typically greenish or brownish in color. In stark contrast, breast cancer typically presents very differently. The classic sign of a cancerous lump is a single, hard, painless mass that is irregular in shape and fixed, meaning it does not move freely. It feels attached to the skin or the chest wall. Unlike fibrocystic changes, a cancerous lump does not fluctuate with the menstrual cycle and persists over time. Other concerning signs include unilateral nipple discharge that is spontaneous, bloody, or clear, skin changes such as dimpling or puckering, nipple retraction or inversion, and palpable axillary lymph nodes. These signs are red flags that demand immediate and thorough investigation. The diagnostic process is crucial for differentiation. When a woman presents with a breast lump, the initial evaluation includes a detailed history and a clinical breast exam. The patient's age and menstrual history are important factors. For a woman under 30 with a lump that feels consistent with a fibrocystic change or a simple cyst, an ultrasound is often the first imaging study performed. For a woman over 30, or if there is any suspicion of malignancy regardless of age, a diagnostic mammogram and an ultrasound are typically ordered. The definitive diagnosis, however, always comes from a tissue biopsy. A fine needle aspiration or core needle biopsy can confirm whether the cells are benign or malignant. The primary danger zone for the FNP is diagnostic complacency. Never assume a lump is benign based on a clinical exam alone, especially in a postmenopausal woman, or if the lump has suspicious features. Dismissing a patient's concern without a proper workup can lead to a delayed cancer diagnosis, which can have devastating consequences. Another critical point is to educate patients about breast self-awareness. Encourage them to know what is normal for their breasts and to report any new or persistent changes promptly. While fibrocystic changes are common and benign, any new lump requires a full evaluation to rule out the possibility of cancer. Contraceptive methods can be broadly categorized into several groups, each with unique mechanisms, benefits, and drawbacks. Hormonal methods, such as combined oral contraceptives, the patch, and the vaginal ring, work by preventing ovulation. They are highly effective when used correctly, but carry risks like venous thromboembolism, especially in smokers over 35 or women with a history of blood clots. Progestin-only options, including the mini pill, the depot-medroxyprogesterone acetate injection, and the implant, are safer for women with contraindications to estrogen. Long-acting reversible contraceptives, which include the hormonal and copper intrauterine devices and the implant, are the most effective reversible methods due to their high rates of continuation and, their forgettable nature. Barrier methods such as condoms and diaphragms work by physically preventing sperm from reaching the egg. Male and female condoms have the significant added benefit of protecting against sexually transmitted infections, a crucial advantage not offered by hormonal methods or IUDs. Their effectiveness in preventing pregnancy, however, is highly dependent on consistent and correct use with every active intercourse. Fertility awareness-based methods involve tracking the menstrual cycle to identify fertile days and avoid intercourse during that time. While they have no side effects, they require significant patient motivation and education, and have higher typical use failure rates compared to other methods. Patient education and shared decision-making are paramount when counseling about contraception. The best method for a patient depends on her health history, lifestyle, reproductive goals, and personal preferences. A thorough medical history must be taken to screen for contraindications, using tools like the U.S. Medical Eligibility Criteria for contraceptive use. For example, a patient with uncontrolled hypertension or migraine with aura should not use estrogen-containing methods. A discussion about effectiveness should compare perfect use versus typical use failure rates to give a realistic picture. It is also important to manage expectations about potential side effects, such as irregular bleeding with progestin-only methods or heavier periods with the copper IUD. A significant danger zone is prescribing a contraceptive method without a complete medical history. Overlooking a contraindication, such as an undiagnosed VTEL risk or a history of breast cancer, can lead to serious adverse events. Another pitfall is failing to provide comprehensive counseling about STI prevention. Remind patients that only condoms protect against both pregnancy and sexually transmitted infections. Finally, ensure patients understand the warning signs for their chosen method. For combined oral contraceptive users, this includes the ACE acronym: abdominal pain, chest pain, headaches that are severe, eye problems, and severe leg pain. Prompt recognition of these symptoms is critical for patient safety and requires immediate medical attention. Menopause is, a natural biological process, defined as the cessation of menstruation for 12 consecutive months, and it marks the end of a woman's reproductive years. The transition leading up to this point, which we call perimenopause, is often characterized by significant hormonal fluctuations, primarily a decline in estrogen. This shift is really responsible for a wide array of symptoms. The most common and well-known are vasomotor symptoms, like hot flashes and night sweats. Women may also experience urogenital atrophy, which can lead to vaginal dryness, painful intercourse, also known as dyspareunia, and increased urinary urgency or infections. Other common symptoms include sleep disturbances, mood swings, irritability, anxiety, and cognitive changes that are often described as brain fog. Management of menopausal symptoms should be individualized, focusing on the patient's most bothersome complaints and her overall health profile. For mild symptoms, lifestyle modifications can be highly effective. These include things like dressing in layers, avoiding triggers like caffeine and alcohol, using fans, and practicing stress reduction techniques such as yoga or meditation. For vaginal dryness and dyspareunia, over-the-counter vaginal moisturizers and lubricants are considered first-line treatments. If these are insufficient, low-dose vaginal estrogen preparations, whether creams, tablets, or rings, can provide local relief with minimal systemic absorption, making them a safe option for many women, including some breast cancer survivors, after consultation with their oncologist. For moderate to severe vasomotor symptoms, menopausal hormone therapy, or MHT, is the most effective treatment. The decision to use MHT requires a careful discussion of its benefits and risks. For women who have a uterus, MHT must include both estrogen to treat symptoms and a progestin to protect the uterine lining from endometrial hyperplasia and cancer. For women who have had a hysterectomy, estrogen alone is used. MHT is most appropriate for healthy, symptomatic women who are within 10 years of menopause or younger than age 60. Contraindications to MHT are significant and include a history of breast cancer, coronary heart disease, previous VTEL or stroke, and active liver disease. The primary danger zone in managing menopause is the inappropriate prescription of MHT. Prescribing estrogen-only therapy to a woman with an intact uterus is a major error that significantly increases the risk of endometrial cancer. Another danger zone is failing to reassess the need for MHT periodically. The goal is to use the lowest effective dose for the shortest duration necessary to manage symptoms. It's also crucial to manage cardiovascular risk factors, as the risk of heart disease increases after menopause. Encourage a heart-healthy diet, regular exercise, smoking cessation, and management of hypertension and hyperlipidemia. And finally, all postmenopausal bleeding must be thoroughly investigated to rule out endometrial cancer. Ovarian cancer is often called the silent disease because, its early symptoms are typically vague, nonspecific, and easily attributed to other benign conditions. This unfortunate characteristic often leads to a diagnosis at a late stage, when, the prognosis is poor. Identifying women at high risk is therefore a critical component of proactive care. The most significant risk factor is a genetic predisposition, particularly mutations in the BRCA1 and BRCA2 genes. A strong family history of ovarian, breast, pancreatic, or colorectal cancer, as seen in Lynch syndrome, also substantially increases risk. Other risk factors include increasing age, with most cases occurring in postmenopausal women, nulliparity, meaning never having been pregnant, and a personal history of endometriosis. The warning signs of ovarian cancer, while subtle, can provide clues if a high index of suspicion is maintained. The most commonly reported symptoms include persistent bloating, pelvic or abdominal pain, difficulty eating or feeling full quickly, and urinary symptoms such as urgency or frequency. The key here is that these symptoms are new, occur almost daily, and persist for more than a few weeks. Other potential signs can include fatigue, back pain, pain during intercourse, and changes in bowel habits. When a patient, particularly a postmenopausal woman, presents with this constellation of symptoms, ovarian cancer must be on the differential diagnosis list. The approach to management begins with a thorough evaluation. If ovarian cancer is suspected based on symptoms and risk factors, the initial workup includes a careful pelvic exam to assess for an adnexal mass. The next step is a transvaginal ultrasound to visualize the ovaries and look for suspicious features like solid components, septations, or ascites. A serum CA-125 blood test is also ordered. While CA-125 can be elevated in many benign conditions like endometriosis or fibroids, a markedly elevated level in a postmenopausal woman with a complex adnexal mass is highly suspicious for ovarian cancer. Any patient with these findings must be referred urgently to a gynecologic oncologist. The most significant danger zone in primary care is dismissing persistent, vague gastrointestinal or pelvic symptoms in a middle-aged or older woman. Attributing bloating, early satiety, and abdominal discomfort solely to irritable bowel syndrome or constipation, without considering ovarian cancer, can lead to a critical delay in diagnosis. There is currently no effective routine screening test for ovarian cancer for the general population. Therefore, the family nurse practitioner's role is not screening, but rather vigilant symptom recognition and risk assessment. Prompt referral to a gynecologic oncologist for any suspicious adnexal mass is the standard of care and offers the patient the best possible chance for a favorable outcome. Polycystic ovary syndrome, or PCOS, is one of the most common endocrine disorders affecting women of reproductive age. It's a complex condition characterized by, a combination of hormonal imbalances, metabolic dysfunction, and reproductive issues. The primary features include hyperandrogenism, meaning high levels of androgens or male hormones, ovulatory dysfunction, and polycystic ovaries on ultrasound. The clinical manifestations of hyperandrogenism are often the most distressing to patients and include hirsutism, which is excessive hair growth in a male-like pattern, severe acne, and androgenic alopecia, or female pattern hair loss. Ovulatory dysfunction typically presents as irregular menstrual cycles, oligomenorrhea, which means infrequent periods, or amenorrhea, meaning absence of periods. The diagnosis of PCOS is made using the Rotterdam criteria, which require the presence of at least two of the following three features, after excluding other conditions that can cause similar symptoms. 1. Oligo, or anovulation, which is irregular or absent ovulation. 2. Clinical or biochemical signs of hyperandrogenism. And 3. Polycystic ovaries on ultrasound. The workup should include blood tests to check levels of total testosterone, DHEAS, and prolactin, as well as a TSH to rule out thyroid dysfunction. An ultrasound is performed to assess ovarian morphology. It's also essential to screen for metabolic comorbidities, as women with PCOS are at high risk for insulin resistance, type 2 diabetes, hyperlipidemia, and metabolic syndrome. Treatment for PCOS is multifaceted and tailored to the patient's individual goals, whether they be managing cosmetic concerns, regulating menstrual cycles, or achieving pregnancy. For menstrual regulation and management of hirsutism and acne, combined oral contraceptives, or COCs, are the first-line therapy. They work by suppressing androgen production and regulating the menstrual cycle. For women with PCOS who are overweight or obese, lifestyle modification with a focus on diet and exercise is a cornerstone of management, as weight loss can improve insulin resistance, restore ovulation, and reduce androgen levels. Metformin is often used as an adjunct therapy, particularly in patients with insulin resistance or prediabetes, to improve metabolic function. A major danger zone in managing PCOS is overlooking the significant long-term metabolic risks. Failing to screen for and manage insulin resistance, dyslipidemia, and hypertension can lead to the development of type 2 diabetes and cardiovascular disease later in life. Another critical area is addressing the risk of endometrial hyperplasia and cancer due to chronic anovulation and unopposed estrogen. It's imperative to ensure menstrual regularity, either through COCs or periodic progestin-induced withdrawal bleeds. Finally, it's important to address the psychological impact of PCOS, including anxiety, depression, and body image issues, and provide appropriate support or referrals for mental health care. Vaginal infections and inflammation are among the most common reasons women seek care in the primary care setting. The three most prevalent conditions are bacterial vaginosis, or BV, vulvovaginal candidiasis, or VVC, and trichomoniasis. Bacterial vaginosis is not a true infection but rather a dysbiosis, an imbalance of the normal vaginal flora where healthy lactobacilli are replaced by an overgrowth of anaerobic bacteria. It's characterized by a thin, gray-white, homogeneous discharge with a distinct fishy odor, which is often more noticeable after intercourse. The vaginal pH is typically elevated above 4.5. Diagnosis is confirmed using Amsel's criteria or by microscopic examination showing clue cells. Vulvovaginal candidiasis, commonly known as a yeast infection, is caused by an overgrowth of Candida species, most often Candida albicans. Its classic symptoms include intense vulvar itching or pruritus, soreness, and a thick, white, cottage cheese-like discharge. Unlike BV, there is usually no odor and the vaginal pH remains normal, less than 4.5. On examination, the vulva and vagina may appear erythematous and edematous. Diagnosis can be confirmed by visualizing budding yeast or pseudohyphae on a wet mount preparation with potassium hydroxide or KOH. Many uncomplicated cases can be treated effectively with over-the-counter or prescription topical or oral antifungal medications like fluconazole. Trichomoniasis is a sexually transmitted infection, or STI, caused by the protozoan Trichomonas vaginalis. It can be asymptomatic in many individuals, but when symptoms occur, they often include a copious, frothy, yellow-green, malodorous discharge. Patients may also complain of vulvar irritation, dysuria, and dyspareunia. A key clinical sign is a strawberry cervix, which refers to punctate hemorrhages on the cervix, although this is only seen in a minority of cases. Diagnosis is made by visualizing motile trichomonads on a wet mount, but nucleic acid amplification tests, or NABATs, are much more sensitive and are now the preferred diagnostic method. Treatment requires oral metronidazole or tinidazole for both the patient and their sexual partners. The primary danger zone is misdiagnosis based on symptoms alone without a proper diagnostic workup, including a pelvic exam, pH testing, and microscopy or other lab tests. For example, treating a patient for a yeast infection based on a phone call can lead to treatment failure if the actual cause is BV or trichomoniasis. Another critical point is to remember that trichomoniasis is an STI, which means partner treatment is essential to prevent reinfection. Recurrent or complicated infections, such as 4 or more yeast infections in a year, warrant further investigation to rule out underlying conditions like undiagnosed diabetes or immunosuppression, and may require a longer course of treatment. Mastering the complexities of women's health is a continuous journey for the family nurse practitioner, one that is built on a solid foundation of knowledge, clinical vigilance, and a deep commitment to patient advocacy. As we've reviewed, the landscape of care is vast, spanning from preventative screenings and contraceptive counseling to the intricate management of conditions like PCOS, menopause, and potential malignancies. Success on your FNP certification exam, and more importantly, in your future practice, hinges on your ability to synthesize this information and apply it thoughtfully to each unique patient you encounter. Remember that guidelines provide a framework, but true clinical excellence lies in the art of applying that evidence to the individual. Upholding best practices means staying current with evolving guidelines for breast and cervical cancer screening, understanding the nuances that differentiate benign from malignant breast conditions, and guiding patients through contraceptive choices with a comprehensive understanding of risks and benefits. It involves managing the menopausal transition with an eye toward both symptom relief and long-term health, particularly cardiovascular and bone health. Your role requires a high index of suspicion for silent diseases like ovarian cancer and a systematic approach to diagnosing and managing common endocrine and infectious conditions. This dedication to evidence-based practice is the bedrock of safe and effective care. Throughout your clinical decision-making process, always keep the key danger zones at the forefront of your mind. These are the moments where a missed step or a wrong turn can have serious consequences for your patient. These include failing to follow up on an abnormal screening result, prescribing contraindicated medications, dismissing persistent but vague symptoms that could signal cancer, or neglecting the long-term metabolic consequences of chronic conditions like PCOS. Recognizing these potential pitfalls and knowing when to act decisively or refer to a specialist are hallmarks of a safe and competent practitioner. Your diligence in these areas directly protects your patients from harm. Ultimately, your journey through FNP preparation is about more than memorizing facts. It is about cultivating the clinical judgment that will define your career. Embrace the responsibility of being a trusted healthcare provider for women across all stages of life. By prioritizing patient education, engaging in shared decision-making, and remaining ever vigilant for red flags, you will not only excel on your exam, but also build a practice founded on the principles of excellence, compassion, and unwavering patient safety. This commitment is the highest standard to which we, as nurse practitioners, can aspire in the service of our patients' health and well-being.